Hello friends, now I will be talking to you about mitral stenosis. So first of all, let's see what are the causes of mitral stenosis. Most common and the most important cause is rheumatic fever. This is the most common cause, but there are few causes, but they are extremely rare causes. For example, it can be congenital, but it is very rare. Why I am saying so rare? It is in contrast to MR, AS, AR, which can be congenital, but this is extremely rare cause as congenital. Similarly, it can be due to mucopolysaccharide, again extremely rare cause. Drugs like methotrexate, again a very rare cause because this drug is not used nowadays. So for all practical purposes, when we talk about mitral stenosis, it is due to rheumatic fever. Now, what is the pathology of this? Pathology. In this mitral valve cusp or so-called leaflets, they are thickened. And there is fusion of commissures, chordae tendineae, then there occurs endomyocardial fibrosis, as well as valvular fibrosis. So ultimately it all lead to reduce mitral valve area. The ultimate result is reduce mitral valve area, and in the advanced stages even there may be valvular calcification. Can occur, but this occur only in the advanced stages. Now let's see what the pathophysiology. Pathophysiology. Let's learn the basic concept. Here is the heart. This is the mitral valve. And the normal mitral valve area is about 4 to 6 square centimeter. is the normal area, but for easy calculation I am taking as 5 square centimeter, and the normal LA pressure is about 4 to 8 millimeter of mercury. Now what happens? This area, when due to mitral stenosis, area is reduced. When the area becomes up to 2.5 square centimeter, then blood is not able to flow freely from LA to LV, from left atrium to left ventricle. There is some obstruction to blood flow is there, and that lead to increase left atrial pressure. This is the most pathognomic feature of mitral stenosis, increased LA pressure. When the pressure goes up to 18 to 20 millimeter of mercury, then, and remember, the blood accumulates in the left atrium. The left atrium expands like a balloon, but remember, LA is a very thin walled chamber in contrast to ventricles, which are thick walled chambers. So LA will expand like a balloon in size, anatomically it will increase in size, and physiologically, as it cannot accommodate much blood, so blood start entering into the pulmonary vein. Back pressure start because it cannot accommodate much blood and blood is not going forward. So what happened? The next step is, after this, pulmonary venous hypertension. So next step after that is the venous pressure increase in the pulmonary vein. Then again back pressure, capillaries. Now after that, capillaries get congested, and that lead to increase in the pulmonary capillary pressure. And after that, this is the pulmonary artery, and that lead to increased pressure in pulmonary artery. So pulmonary arterial hypertension occurs. So all due to back pressure, right? So now right ventricle has to exert a great pressure. Now what happens? There will be, that lead to right ventricular hypertrophy, and later on, as the RV pressure increases, so now even RA has to exert more pressure to push the blood forward. So that lead to right atrial enlargement. So in nutshell, you can say the area is reduced here. So you can see all back pressures are there, right? And as right atrial enlarge, right atrial pressure will increase, that lead to increase JVP also, or right heart failure. So that lead to, ultimately it lead to right heart failure, raise JVP, right heart failure. All these will are due to back pressure features. It's clear to you? Now let's see. This was all due to pressure effect what we are getting. Now just now we learned that LA size is also increase, anatomically also increase. As LA size is increase, just behind the LA goes left recurrent laryngeal nerve. Now before I proceed further, let me tell you one basic anatomy feature. LA is the highest chamber in the heart, and LA is also the posterior most chamber of the heart. This is the peculiarity of the normal LA. So as LA is getting enlarged, behind that is going left recurrent laryngeal nerve, left recurrent laryngeal nerve. So it get pressed because of enlarged LA. So that lead to hoarseness of voice. That lead to hoarseness of voice, what we call as Ottoner syndrome. Ottoner syndrome. Some author they spell like this also, either way, syndrome. Just behind LA also goes the esophagus. An enlarged esophagus will compress, enlarged left atrium will compress esophagus, that lead to dysphagia. Dysphagia. Again due to pressure effect. And as capillaries are congested, so that lead to hemoptysis. And as capillaries are congested, so that lead to dyspnea on exertion. Dyspnea on exertion. So in fact all these are the symptoms also by which patient come to us. But now you also have learned why this symptom will occur in these patients. Okay, we talk further. As LA has become enlarged, now it has become very thin walled. So now this LA is prone for atrial fibrillation. This patient is prone to atrial fibrillation. So as the atrial fibrillation occurs, atrial rate is very high, so that lead to increase in the ventricle rate also. So that's why the most common presenting symptom of AF is palpitation. Palpitation. Palpitation occurs due to rapid ventricle rate, and due to same reason patient also develop pain chest. Pain chest. So the symptom like palpitation, pain chest, which may occur in mitral stenosis, but they occur in very advanced stages or late stages of mitral stenosis when the patient develop atrial fibrillation. So friends, you are clear about the clinical feature also, which we have covered. Like this, we have additional clinical features, and due to dyspnea on exertion or due to lung congestion, patient may develop orthopnea. And all due to back pressure, patient may even develop edema feet. All due to back pressure. Right? Now, on examination, what we will get when we examine the patient? You get loud S1. S1 is loud because LA pressure is very high, So valve get closed with a great pressure. Well, patient can develop opening snap. Now, opening snap occur due to opening of the mitral valve. As you know very well, opening of, normally when the mitral valve open, they do not produce any sound. But here LA pressure is very very high, about 18 to 20, so these valves are opened with a great pressure. So they produce a sound, so called opening snap. Now opening snap, we have one more advantage. If opening snap is present, it means the valve is pliable, it's not calcified. But as we discussed earlier in the pathology, there can be valve calcification in the advanced stages. Once the valve get calcified, the opening snap will disappear, even S1 will become soft. S1 becomes soft. So if in a case of MS you are getting soft S1 and opening snap is not there, it itself indicates the valve is calcified, which you can confirm on echocardiography. Right? What else we get on examination? You get mid diastolic murmur, which increases on pre-systolic accentuation. Pre-systolic accentuation. Occurs. Then P2 is loud. This occurs due to pulmonary arterial hypertension. There is left parasternal heave. Left parasternal heave, this is due to right ventricle hypertrophy. So this is all due to right ventricle hypertrophy. In the advanced stages, you may get murmur of PR, pulmonary regurgitation. This murmur here, so called Graham Steele murmur. Graham Steele murmur. This is due to pulmonary regurgitation. Okay. So now we talk about the investigation. In investigation, most important investigation is, or you can say best initial investigation is always echocardiography. Echocardiography is the best initial investigation. We can go for transthoracic echo, but transesophageal echo is much better. Is much better because it can visualize the LA and the valve in much better way. Otherwise, in ECG, we get increase LA enlargement, right ventricle hypertrophy, right atrial enlargement, and this you see as P mitral in ECG. And this you see as P pulmonale on ECG. In chest X-ray, PA view. You get straightening of left border of the heart. Then LA get enlarged, so you get double density picture of left atrium. Then left bronchus is elevated. Curly B line. They are seen in the advanced stages when the patient has developed pulmonary congestion. They are all X-ray finding in these cases. Now we talk about treatment. Now before treatment, I like to add one more thing. Mitral stenosis is more common in females, and the problem increases during pregnancy. The reason being, in pregnancy the plasma volume increases by 30 to 50%. So now more and more blood has to flow from the narrow mitral valve, and due to increased blood volume the lungs get congested, and that add more to the load on the heart. That's why patients are more symptomatic. So now when the patient come to us, we have confirmed that patient has mitral stenosis. The best initial treatment is always diuretic, is the best. We can give drug like furosemide. They will reduce the intravascular volume, and thereby they will decongest the lungs, and patient will have immediate symptomatic improvement there. We can use digoxin if patient develop atrial fibrillation. What is the mechanism of action of digoxin? So here is the heart, here is the AV node, and as you know, in atrial fibrillation the heart is beating in a very unorganized way, and there are impulses are coming from everywhere, not from SA node, but from there are multiple foci from the impulse are coming. So about large number of impulse, maybe around 450 to 600 impulse come to AV node, and AV node, you know, has a very has the longest refractory period. So all impulse cannot come down, but maybe out of 450, 150 impulse come down. So ventricle rate is about 150, and that lead to rapid ventricle rate, and that lead to palpitation. This is the reason. So palpitation is due to rapid ventricle rate. So once we give digoxin, it further increases the refractory period of AV node, the ventricle rate goes down. Ventricle rate goes down, the patient has symptomatic improvement and better ventricle filling also. So friends, this is what we treatment what we do, but in some cases we need surgery or some intervention. What are the indication of surgery? What are the indication of surgery? Surgery. First of all, patient has class 3, class 4 dyspnea, Class, class 3, class 4 dyspnea means patient has dyspnea on doing activity of daily life, dyspnea on rest or minimal exertion. Okay, the patient has symptomatic despite adequate therapy. You have planned for surgery, or patient can have recurrent thromboembolic phenomena. Thromboembolic. Why? Because of atrial fibrillation. The atrial fibrillation are a source of thrombus. That's why thromboembolic phenomena can occur in these patients. If these are the problem, then you plan for surgery. Now, what type of surgery we can do? What type of surgery? Balloon valvuloplasty. It is the best, but this we can do only when the valve is not calcified. Once the valve is calcified, then valvuloplasty is usually not possible. In that case, we can go for valve replacement. Valve replacement. We have two types of valve. One is tissue valve. Tissue valve life is about 7 to 8 years, but the advantage is you don't need any oral anticoagulant. Oral anticoagulant are not required. Second is metallic valve or so called prosthetic valve, metallic valve. Here the life is about 15 years of the valve, but the disadvantage is that patient has to take lifelong oral anticoagulant because these are prone to thromboembolic phenomena. So, what are the indication where you will like to use tissue valve? Tissue valve you like to use in following situation. Tissue valve. We use during pregnancy. We use in unmarried ladies, unmarried females. Why? Why in these two conditions? Because we cannot use metallic valve in this. If you use metallic valve, we have to give oral anticoagulant, and in these two situations you cannot give, especially in pregnancy, because this lady will conceive soon later on when she gets married, and during pregnancy we never give oral anticoagulant. Third indication is we use tissue valve in elderly, male or female. Suppose we get a patient around 60-70 years who come with mitral stenosis. In elderly people, we never want to give oral anticoagulant because they itself has got a lot of problems. Okay? So there are three conditions where we use tissue valve. Now, metallic valve. Metallic valve we use in young males of all ages, young male, and in young ladies where family is completed. Where family is completed, in that case you can plan for metallic valve, but be cautious that we have to give lifelong oral anticoagulant. Thank you very much.